if you go back to the Romans, they call it the tremble. Then I became shell shock. Then it was battle fatigue, and now I have PTSD. This name is causing a lot of stigma. It is killing people. If you do have symptoms of PTSD, it's real. It's not because you're weak of soul or anything like that. It's because there is a real change in your brain, and it's possible to fix it.
In a world where trauma often goes unseen, there exists groundbreaking treatment that offers hope and transformation. And our guest today is Dr. Eugene Lipov, a pioneer in the field of PTSD treatment who has revolutionized the way we approach mental health. His innovative dual sympathetic reset procedure has brought relief to countless individuals who suffer from invisible wounds. Dr. G, as the Special Force community calls you, I'm so honored to have you here on the 1 Mile, 1 Veteran podcast.
Great to be with you. Thank you so much for inviting me.
Absolutely. Well, as our listeners begin their walk and start tracking it on the Strava app, I'd love to just jump right in. I'm seeing the sign behind you, Brain, Hope, Reality. Why are we calling it PTSI and not PTSD?
Thank you. So this is actually a sign from my podcast. PTSI, not PTSD. I'll tell you the story behind it real quick. So I have an absolute honor to meet Dr. Frank Ogbert years ago. So Dr. Frank Ogbert, was the number 2 man in NIMH, National Institute of Mental Health. So he's a very famous psychiatrist. He came up with the term Stockholm Syndrome. You may have heard of it. Mm-hmm. So in 2010, he came to a conclusion based on tons of information in his experience that the name PTSD is stigmatizing. So when people are stigmatized, it leads to potentially suicides and other problems. And he started a campaign trying to change the name PTSD to PTSI. So PTSI means post-traumatic stress injury, meaning you can look. So when somebody has an emotional trauma, let's say you see somebody being killed in front of you, there is a brain change that occurs that is measurable on a brain scan. You just need an advanced scan. During the intro, you said there are invisible wounds. So I've been in Washington, I think 2016, they were talking about invisible wound treatments for PTSD. So when it was my time to talk, there was a 2-star admiral there. After I followed him, I said, it's invisible if you have the wrong scanner. You have the right scanner, such as functional MRI, PET scans, and other things. You can actually see the brain change. And if you look at it as a biologic, physiologic change, it is not a lifestyle. You're not stuck with this, right? You can think of like a broken leg. If it's a broken leg, you're not going to live with that, right? You're going to do something about it. You take an X-ray. Okay, leg is broken. The same thing can be done with the brain, fMR. Instead of putting cast on, you can do something, stellate ganglion block, which we'll talk about it later, or other things which are effective. But I did a survey in 2023. We asked 3,000 people, if we change the name PTSD to PTSI, will the stigma get better? And most people said yes. Half were veterans, half were not veterans. So the point is, civilians or not civilians, it doesn't matter. So in 2013, Frank Ogbert and Peter Chiarelli, who was a 4-star general in charge, he was a line officer, not medical. So he and Dr. Ogbert went to American Psychiatric Association. They said, this name is causing a lot of stigma. It is killing people. Now, Pete Chiarelli knew a lot about suicides because he was in charge of the Army suicide prevention. That was his function. And he said, the name change, I've talked to my people, and name change will save a lot of lives. And APA said, we're not doing it. So now we're 2023. I presented my findings to APA, and they told me the same thing. No. I applied for official name change. It took about 6 months of all this. So it's interesting, in order to change the name in psychiatric, it's called DSM. Mm-hmm. So APA requires one basic requirement. If you can demonstrate harm, that it will change the name. If you can show that one thing, if the name causes harm, let's change the name. Okay, makes sense because you can change the name, right? So if you look at DSM, they have changed a number of names recently. One of them was learning disability. It was felt to be stigmatized, and they changed it to learning differences.
Yes.
So I used the same argument. I said, we know PTSD causes harm because it leads to stigma. Stigma kills. No question, no debate, nothing. I sent to them and they sent me a very polite letter. I'm going to send you that information. It's all on my website, itsptsi.com. If you want to see all of that and Pete's testimony, it's all documented. It's all there. And they said, well, you don't have enough information, so no, we're not going to change it. That's chaotic.
This is that mundane work that has to go through these systems when they talk about like bureaucracies and difficulties within healthcare. Like this is one of those things. One of the things that I also know about within the veteran community, because at least from the people that I've talked to, is identifying things as a veteran disability claim. It's medical compensation for injuries that have worsened or occurred while we were in service. And yeah, we're still going to walk with a limp. So like PTSI, I'm still going to have scar tissue from my time in trauma or my time in Iraq and Afghanistan. That's still going to affect me. However, my belief is that the ongoing therapies are going to give me the skills that I'm no longer walking around with the disorder. I'm just aware that, hey, this is some scar tissue. This is, when we get cut and we developed scar tissue on our skin, like it's always going to be tough. And so is that kind of the same thing with PTSI? Like,
no, because if you look at it, I'm not a psychiatrist. Let me just give you my background, right? I'm an anesthesiologist with a couple of years of surgical residency. I did trauma surgery. So I don't believe in this. Well, you'll get better in about 20 years. No. If it doesn't work immediately, I want nothing to do with it. I mean, that doesn't work. So to me, a result is when you do something and people feel, oh my God, I feel so relaxed. I feel great now. I can actually function. I can sleep. I can have sex. I can work. That's a result. So the problem is, with all the respect to my psychiatric colleagues, I think there's a lot of amazing things I do. But a lot of times people are bought into this 20, 30, 40 years of psychotherapy work. I don't think it has to be a lifestyle. What we find is, if you think about it, it really makes sense. If you're running from the tiger is about to bite your patootie. Your fight and flight system is going into full overdrive, right? Let's see what happens. So you're not going to have sex. So 85% of men with PTSD have sexual dysfunction. Not a surprise. If you are in fight and flight condition all the time, your coronaries are collapsed. So people who have PTSD, their chance of having a heart attack is 2-3 times higher than somebody who doesn't have PTSD. Right? So it's all physiologic. If the stress is severe enough or enough period of time, your sympathetic nerves, of fight and flight nerves in the brain, grow extra nerves. And those nerves produce norepinephrine. That's been shown in a rat model, and the increased norepinephrine has been shown in humans, actually. So as long as that persists, you can't sleep, right? Because the tiger was trying to bite you, you can't sleep after that. So it all makes sense. So you can tell somebody, it's like, you're really not feeling that, it's really not that bad. I don't see how that's going to solve that problem, right? So that's the problem. So that could be a long-term operation. So what we find the most effective is we do stellate ganglion block, or DSR, dual sympathetic reset, which is a more advanced version of it. And what that does, it reduces fight and flight transmitted norepinephrine, like in 5 minutes. So people feel like, oh, I can take a full breath now, first time in 20, 30, 50 years. I took care of a veteran from Vietnam who had not felt an emotion in 50 years until we treated him. 50 years, right?
wow.
Right? He had alcohol problem, he has opioid problems, this problem, whatever. And then if you add on focused trauma-informed therapy, that's beautiful. Then it really works and people can participate. So in a couple of months, you may be fully functional. So you're done. You're talking about the scar tissue. Brain is kind of a little different, right? So if you look at it, the closer muscle is not as good an analogy for here. Think of a computer, right? So you have a computer and you have a bunch of programs running. Eventually it becomes a slug. It moves very slowly, right? What do you do then? You reboot the computer. Stellate or DSR does the same thing. We reboot the computer to pre-trauma state, and people can function immediately quicker. That's the difference. And we have our first DSR baby. I'm happy to report. We have one patient, not military. He was first responder, severe PTSD, and he and his wife was trying to get pregnant for 20 years. So they're now the early 40s. So they didn't go to real doctors, but they've tried significantly, shall we say. So we do the block. 2 years later, he calls me up. He says, guess what? We got pregnant the day after the procedure. So they called the child Jordan because I'm in Chicago. Is that a cute story or what?
That's amazing, to make this change and this reality, because it is a bit of a head game for people to wrap their minds around what stigma actually means. We throw the word stigma around all the time, but when people are actually living with the stigma, when we're afraid to come down with the disorder, it means that we're going to have a lifetime of consequences. But when we have an injury, there's a recovery process.
Right. You get better.
Exactly. So what started you along this campaign to begin really investigating PTSI?
Actually, my journey started before I was born, believe it or not. So my father was a flyer in World War II. So his squadron, they did Navy aviation. Their lovely job was to drop bombs and torpedoes on German ships. So out of 10,000, 100 made it home. So he had severe PTSD, and I think it actually, there's a whole science we can talk about later if you like, epigenetics. So DNA changes, and it's passed down 3 generations from traumatized person. So my father was traumatized, he gave it to me, and then he eventually gave PTSD to my mother. That's called secondary PTSD, which is something I'm very interested in. So a soldier come home, his behavior leads to PTSD in typically a woman, and it's a whole mess. So we've now, a lot of times we treat the whole family unit. Anyway, so both of my parents were physicians, and then I was a first year resident in surgery. So my mother took her life when I was a first year resident. She was under care of psychiatrist, so on medication. So I was not a fan of her treatment, you can imagine. So at that point, I used to like psychiatry. I was interested in it. But after that, I said, I'm not really, I have nothing to do with that. I want nothing to do with that specialty. I ended up in pain medicine. And so it's anesthesia and subspecialty is pain medicine. And I've been doing this procedure called Stellate Ganglion block for CRPS, which is a burning of the hand. It's been around like that forever. The first time I did the Stellate Ganglion block was 1987. And then I had a patient that had severe hot flashes. And then that patient, I said to my brother, I said, take care of hot flash. I don't do hot flash. That's not my thing. He said, just do this block thing. And because it takes away the whole sweating of the hand and it'll help her with hot flashes. He couldn't help her. He tried medications. So I did the block. I took it away. And to speed things up, the newspaper people attacked me. They said, yes, it works. You don't know how it works. So you're a complete idiot. And they attacked me pretty good. And that's was 2005. So that gave me a lot of encouragement to figure out why did it work for hot flashes. So I read about 3,000 articles. And one of them, in Finland, they were doing T2 clipping, which is basically take the lung out of the way, you put a tube in, and you clip fight and flight nerves to take away hand sweat. And they found that PTSD stopped. And I read that, I was like, what? That's crazy, right? So then I looked at the anatomy, and it turns out this T2 ganglion becomes stellate ganglion and goes up to the brain. So I called up my brother again, and I said, hey, send me a patient with PTSD, see if I can help them. So he had a patient that was robbed at gunpoint. I did some nasty things to him. He's on his way to his psych ward 2 months after the trauma. So we did the block. He didn't have to be admitted. So I published that in 2008. And then I published a theory how it worked 2009. So Dr. Mulvaney from Walter Reed called me and he said, is this like real or is it complete bullshit? So he followed my work and that's how it got into the military. And that's where it all came from. Isn't that weird?
That's absolutely a wild way to get into this field. I want to talk about Normandy real real quick, or World War II. Last year, I had the ability to go to Normandy during its 79th year anniversary of the invasion, and we not only visited the sites, but we also visited just the American cemetery that was there. And there are tens of thousands of American soldiers laying there and sailors laying there in this cemetery at the beaches of Normandy. And I couldn't help but think of the survivors, because people often ask me, they try to get in this conversation about, why aren't our soldiers and our Marines tougher? Why is this now an issue? Why is this such a hot topic? And when I was sitting at the beaches thinking about the survivors that came home, because that was a 3-day battle where just tens of thousands of people died.
Right.
And they came home and they didn't talk about it. And everybody just thought that they were fine. And what I revealed to them a lot of the times, because of my own family history, is they didn't come home fine. They came home and they beat their children and their wives, and they drank themselves to death, and they didn't deal with it. And so the trauma only compounded down generations when we stopped learning how to deal with it. And with a country that's been in war as frequent and as often as America, and just a world that's constantly in war ever since World War II, these traumas are only compounding because we, one, didn't know to deal with them, and two, didn't know how to deal with it in a healthy way. And so, I want to know kind of what your thoughts are on this, because you had mentioned you're able to pass on PTSD to your children, and then you're also able to transmit your PTSD into secondary PTSD, which is what affected your mother and eventually led to her dying by suicide.
That's exactly right. Basically, if you look at epigenetics, people think genetics, in order to change genetics, you need to have a mutation, like complete change. That's not true. You can actually change the DNA by your behavior or by the environment. So what happened to my father? So he was part of World War II, and a lot of those guys drank heavily, and they called it silent generation because they believed they suffered quietly, they had no problems. That's totally not true. First of all, if you go back to the Romans, they call it the tremble. So, I mean, it's like they had the same PTSD problems. It doesn't matter. The names just keep changing. By the way, here's an interesting tidbit. You know the first name for PTSD symptoms in the modern era? Soldier's heart from Civil War, right? You probably never heard that name.
No, not
But
at all.
soldier's heart is a physiological description. They looked pale, they were sweating, they couldn't breathe right, physiological. Then became shell shock. Then it was battle fatigue, which was World War II. Then Vietnam syndrome, and now we have PTSD. That started in 1980. But my point is the name keeps changing, but with all the respect to the people in neuroscience have taken a lot of changes in the last 50 years. We know a lot about the brain. We know which part of the brain is activated in PTSD. It's called the amygdala. Everybody knows that. Like Peter Chiarelli talks about the amygdala a lot, and he is a line officer. He's not a neuroscientist. So as far as DNA, so what happens is the DNA that my father gave me made me more prone to develop PTSD. So they say, the nature loads the gun, circumstances fires it. So if he was a calm guy, he didn't have PTSD I may not have developed PTSD. But and I had to get my treatment. But my mother, that's another very common example. If you think about it, you can think about PTSD. Whenever I say PTSD, you should be hearing PTSI, but I'll just keep it simple. So when somebody comes, so people can think of PTSD as an infective agent. So if you come home, you can give that to everybody in the house. Question is, how could that be? How can you catch a mental disease? So let's say somebody comes home and you don't know if they're going to beat you or hurt you or do something bad to you. How are you going to live like that? So if you talk to a lot of the women who typically it's women, not everybody, of course, but because a lot of the wives or significant others at home try to prepare for reentry back into the house from the husband. Some of them close the shades, they tell the children to be quiet, hide, because you don't know what's going to set the person off. All of that actions is done to survive. That makes perfect sense. But think about what it does to the kids. When daddy comes home, you don't know he's going to say lovely things or throw against the wall. That is threat. There's always an implied threat. And they probably have the DNA already prepared to be overactive. If you think about why God made it, if you're a caveman and you have tigers walking around your cave, you want your children to be on high alert continuously. So it makes sense in that space. But does it make sense here? I don't think so. I don't know if that answers the question though.
No, it absolutely does, and it brings me to my next one about childhood trauma, because a lot of us, especially a lot of us that end up going to war, we are coming from traumatic childhoods, or people that develop chronic PTSI or PTSD. We're coming from areas of childhood trauma, and so what does this effect look like in the long term of an individual from the childhood trauma?
I consider I've had childhood trauma. So for example, I've had the absolute honor to take care of SOF, Special Operative Force, not just SF. That's just the Army, right? Have to be very careful with that, very respectful. No, I've been trained very well by amazing people. But about 70 to 80% of them had terrible childhoods. So what it does, a terrible childhood, I think it makes you the ability to do, and I in quotes, superhuman things. If you think about, you were in the military before, so you you probably know the difference between boot camp and special forces training, right?
Yes, sir.
Go through the boot camp, and then to become a Green Beret, it's one more level up. And I took one of my buddies as a ranger, and he said, I just wouldn't give up. I'm not going to give up. And that's what it takes. And that's like 10% of people. Then you have the Delta Force, which is one more level up. But my point is, I think it's my personal idea. I have never studied it, I haven't read about it. But I think when people have a hard childhood, they seek the environment where they have control and nobody's going to do anything bad to them. They feel very confident in that. But also, when it's really hard around them, they would go, ha, that's nothing compared to my childhood. Like when I went to Cook County Hospital, which is considered at one point like the hardest place to train for surgery in the United States, I was thriving, and they go, you think it's a great time? This is disgusting. This is a horrible place to work. People are trying to kill us. It's disgusting. We don't have the equipment. I said, it's so much easier than my home. What are you talking about? This is so simple.
No, absolutely. I mean, I remember getting notification of my first deployment to Afghanistan, and my supervisor was asking me, because I had volunteered. I was new on island, and the deployment was 30 days away. And they're like, "Are you nervous to go to war?" And I said, "No, like there's nothing really to be nervous about. Like we have the training, we have the skills. This is going to be an adventure."
Exactly. But that's a different perspective, right? So if you didn't, I would say if you had a light childhood, you go, why am I doing this? I'm going to stay in my comfy chairs and enjoy everything. Why am I doing this to me?
Yeah. Now, with the development of our mental health issues into PTSI, as I ended up developing as a result of 3 combat tours over the course of 6 years, I've gone through various treatments, and one of them that I heard about for the first time back in 2018 was yours, of the stellate ganglion block for treating PTSD. I haven't had a chance to actually receive the treatment for it yet, but could you explain what it is and how it works?
Yeah, absolutely. So, by the way, I'll extend you an invitation. If you'd like to come in, we can record this for you. You can put it up on your channel if you'd like.
Oh, that'd be amazing.
Yeah, if you need to bring your bride, we can do that too.
I love it.
Yeah, I mean, I'm very passionate about primary PTSD, secondary PTSD, and childhood PTSD. For you understand my reason, I think now pretty clearly. Anyway, so to understand what it does, you need to understand what PTSD is or what it's not. So it's basically a physiological response. So the ganglia is basically where the nerves connect to each other. So there is a ganglion that connects in the neck. From the nerves from the spine that connects from here, then there is a connection here. It goes up to the brain. That's been shown in a number of studies using rabies virus. So we know for a fact that's a fact. So when somebody has severe trauma, fight or flight nerves start to produce norepinephrine. That's what makes you hyperventilate, look around. Like, let's say you almost got hit by a bus, you're all jittery. That's norepinephrine. But at the same time, a substance produced called NGF, nerve growth factor, it's called neurotropin. It means if I inject that inside the brain, let's say in a rat, it'll make fight and flight nerves grow, just how God built it. So that NGF is produced in the brain, and it's carried from the brain through the fight and flight nerves to the ganglia. Once it hits the ganglia, it makes the nerve grow. So instead of 4 fight and flight nerves, let's say we have 8 now. Each one of those guys produce norepinephrine. So as long as that continues, you have too much norepinephrine, you're going to have all the symptoms: hypervigilance, can't sleep, impulsivity, all those things. By the way, those last 2 things is what leads to suicide: impulsivity and sleep dysfunction. Mm-hmm. So what happens when you do a local anesthetic, which numb it up basically? 2 things happen. Immediately, norepinephrine drops in about 5 minutes because it's absorbed into brain tissue, and people feel better. They go, "Oh my God, I don't have the feeling of doom anymore." It's such a beautiful thing to see. It's amazing. Or we had a lady here. She started crying. She said, "I didn't know I could be comfortable again. Not since 5 years old have I felt that comfortable." Those kind of responses. The second thing that happens is somehow or other, through complex mechanism, local anesthetic knocks out the NGF. The nerve growth factor goes down. In order to maintain the extra nerve growth, you need to have NGF. So if you take off the NGF, it goes back to normal. So now instead of 8, you're back to 4. So a local anesthetic that lasts 8 hours can last for years because you took away the fight and flight nerves. Technically, it's called pruning in the neuroscience literature, but you took it back to normal level of sympathetic nerves. That's why the symptoms are not coming back in many people for years.
That's so interesting. You've already mentioned a few amazing successes that you've had over the course of developing this treatment and how you ended up getting into the military line of work for PTSD treatment. How effective has SGB been in your experience, and why aren't more people taking advantage of it?
First is easy. Second is not going to be a pleasant answer.
Okay.
So success rate, I would say. I modified the technique. Let me tell you the story where double block came from, or one of my captains from Iraq friend called it double cheeseburger. So we had a patient that I took care of. He had back pain, and he was a sniper in the Marines. And he came in and he talked me into doing the block. He was suicidal. It was a horrible station. So I do the block on him, Stellate, C6 block, and he says it's not working. I'm going to go home, kill myself. I was beyond scared. So this 45 minutes goes by. By that point, it usually works. So before I got into the PTSD ward, I was teaching in Norway, and I learned this block, superior cervical ganglion block, which is higher up. So I took the guy back because I was so frightened for him. So we do the block. 5 minutes later, he says, "I feel great. Thanks." He survived. So then I figured out the neuroscience behind it. Anyway, it turns out when you do 2 levels, it seems to do a better reboot than 1 level. So that's why we do DSR, or dual sympathetic reset block. Success rate is probably in the 80% at this point, and that seems to be consistent with, like, say, Dr. Mulvaney, who's done similar work. Why is it not accepted? I can give you 3 answers. So answer number 1, I think it's a weird approach. Most people are not used to something that is a anesthetic block to have a psychiatric impact. It's just weird. It's weird for most physicians, let alone lay people. I think that's just weird. And there are special interest groups that we're not going to go into that will have a reason for that not to be highly successful. But I think those are the 2 reasons. And it's still also insurance doesn't cover this. So a lot of times we've set up a non-for-profit to get some people to help that. Especially special forces guys, we've treated a lot of them because they have a more active non-for-profit community. But I think there's no real coverage. And there's still, almost every week I talk to psychologists, psychiatrists, they go, I don't believe that works. I was like, have you read any papers? No, but I don't think it's going to work. It's like, okay. The first publication came out in 2008. There was a study done in Fort Bragg, Tripler Hospital, and Lenheim, published in JAMA, Psychiatry, big journal. There's a big study being done in NYU. There's some pretty reasonable science, and it's been replicated in multiple institutions, naval hospitals, and things like that. No, not interested. Thank you very much. So I'm going to leave that be.
No, it's 100% understandable when we think about medicine as a business, right? Like, obviously there's conspiracy theories of it. I think a lot of doctors like yourself want to heal people. They want to see their patient come in, produce the results, give them some follow-on care, and then say, you're good to go. You don't have to come back here. Like, that's the ultimate goal, especially when dealing with mental health injuries.
Let me just give you a piece of information. Well, thank you for saying injuries. So PTSD is an $8 billion a year industry. So you decide how that works.
Yeah, totally understandable. When we're talking about the other therapies, let's talk a little bit about the other therapies that are currently being offered to veterans. Therapies that I've gone through, EMDR, I've gone through one of the harder experiences that I did have that almost led to me was exposure therapy. Yes, I started it around the holidays of 2019. And by February of 2020, before the pandemic, and I really try to emphasize the pandemic had nothing to do with my near-death experience, I came home for the first time in 10 years of therapy, willing and planning my death. And the only thing that got me out of it was doing what I knew to do, which was to tell those around me exactly what I was going through. Like, that to me was the most effective, was talk therapy, was saying, hey, this is what's going on inside my head. I just need to get it out. That's always been the most effective thing for me, especially being a recovering alcoholic. I'm very wary of drugs and other treatments. And so, what modalities do you feel could be dangerous, like MDMA?
So let me give you a complete answer, if I may. So first of all, notice you and I didn't talk about the exposure therapy, right?
Right.
So that's one of the things being offered. I think that is the craziest idea in the world to me. So think about it. If you have a broken leg, do you want to put a cast on and kind of heal? Or do you want to run up and down the mountain with a broken leg? Exposure therapy is running up and down the mountain. So the idea, for those people who don't know what that is basically the idea is you keep seeing things which are relevant to your trauma, and the being re-traumatized will miraculously resolve everything. Well, the initiator of that whole plan, she and I had quite the argument about that, which kind of ended our discussion. But think about it from my perspective, physiologically, right? Fight and flight system. If anybody hits you in the face once, your fight and flight system is going to do something. You're going to run away, you're going to beat them up, right? But in exposure therapy, you need to get whacked in the face 20, 30 times. Shockingly, it does not help. Shockingly, it can make you suicidal. You're the example of it. By the way, alcohol abuse, it's very interesting. I have a lot of experience with that in special forces. What's interesting is, I'll give you a classic example of it. I had a guy came in, he was a lieutenant he was a SEAL, I think Team 5, I'm not sure which team exactly. Anyway, so he drank a liter a day for 10 years. He did the block, he stopped like that, never picked up a glass. The question is, why would that be? The reason people drink, it's a symptom of trying to calm yourself down. They're not doing it because they have weakness or moral weakness or whatever the term you want to use. All they're trying to do is calm themselves down, and they have a moment of peace. I'm not advocating alcoholism, but I'm saying is instead of looking at the disease, you should look at the symptom of PTSD.
Yeah, absolutely. I mean, that's what was going on with me.
Right. So if you want to calm yourself down, there's a couple of choices, right? You can treat the fight and flight system, which is stellate. You can drink yourself silly. You can take a major tranquilizer and go to sleep and get fat and stupid. I mean, those are the choices. You can do exposure therapy. So back to the original question. Um, so MDMR, I think, offers a lot. I think it's a good modality. CBT, I think, works well. Cognitive behavior therapy. It has its moments, but if you can reduce the fight and flight system first, I think that's the crucial piece. And we've had some amazing results with that. Some of the new modalities are TMSs, transmagnetic stimulation. Pretty
Okay.
good. Slow. It takes 30 sessions. It takes a while to go to it. There's ketamine. It has some good and bad. Commonly, by the way, we combine now ketamine and DSR together for especially SOF. I call it SOF method, special operative force method, because the amount of BTBI or blast TBI that happens from just the training is significant. I've experienced it personally because I did just a little training and I got a little BTBI. I was like, whoa, hold on there. Anyway, so it's interesting that you can actually heal the brain injury using ketamine. And so there is a synergy when you combine ketamine and DSR. If you're interested in looking that up on my website, dreugenelipov.com, you can actually download the paper. It explains the biology and all that. The one that I think psilocybin really has a lot of promise. I think it's safe. And I really think it has some really good potential for alcohol use, for PTSD, for anxiety, for depression. It has some really good things. Now, back to MDMA, my favorite drug. Not. So MDMA was supposed to be the answer for PTSD. It was about to be approved, but then FDA took a look at side effects, people getting overheated, fast heart rate, other things. So keep in mind, MDMA in it used to be called ecstasy, or the same drug. So in 1970s, it became clinically available. It was the love drug, like who make the couples love each other. And then from there, it jumped to the clubs. And I want to give you a very interesting excerpt what happens when people use in the club. So there was a club owner who was very interesting. So he would go give away ecstasy. Just go ahead, take it. And he would charge somebody $100 for a bottle of water because you start to get so hot from that, people buy the water. People were drinking water from the toilets because they were overheating. It can actually kill you, right? It has significant downside. So I'm glad they're taking another look at that, frankly. So I think psilocybin's good. Most of us real psychedelic like LSD, I think that's probably going to be successful, and other ones will be successful. But NDMA, they're going to take a very hard look at it. So this all happened. The lack of approval happened on the 3rd of June. So I was listening to a podcast by AP, and there was a gentleman there. He is an Army Ranger, and he stated, which is really, I thought it was irresponsible in my opinion. I tried to get a hold of him, but shockingly, he didn't respond to me. And on his website, he says he is a psychedelic enthusiast or whatever. He embraces the therapeutic modality. He believes there is no other treatments available besides MDMA for PTSD. I would say, A, he's not a doctor. He's not a neuroscientist. He's nothing like that. With all the respect, being a ranger, okay. In what universe is it right for him to say that? And in what universe is that okay for AP to publicize that without consulting somebody who actually understands something about it? That's just wrong. Psilocybin, great. If you want to go that way, great. DSR, great. Other modalities, great. Ketamine, great. But the only thing available now, they took it away from us, and there's no other treatment. If you take away hope from people with PTSD, you know what's going to happen.
Death rates are going to go up.
You know what the suicide rate is currently, by the way? Have you seen that number in military?
The common one is 22, but it's currently believed to be 44.
Yeah, exactly. I have that study. A buddy of mine did that study, actually. That's a mind-blowing number to me. How can we... And then I mean, so how about this? In my universe, if I had a choice, here's what I would do. Step one, change the name PTSD to PTSI. Stop the shaming of the people who served our country and their spouses and their children. Say it's a biological condition. I think right there, it will do what you were able to do. Thank God. That's why you're here. You were smart enough or strong enough to be able to tell people, help me. The people who helped you is probably not psychologists, psychiatrists, probably your friends or your family.
Exactly.
So you said, hey, I'm in trouble, help me. But if you have this PTSD, I'm going to be with us forever. Why would you even bother? They're not going to do anything anyway. So if you're suicidal, I used to be an ER doc. You know how they decide if somebody is suicidal or not? Yes, are you suicidal? No. And the only reason I say it, if that's the first time they go, they may say yes. The second time they go, no, 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 no. Because what happens in the hospital, you get admitted, they talk to you, they give you drugs that take maybe 3 months to work. You're not staying in hospital 3 months, and they kick you back out. Right? The guy who killed the best sniper, the guy sniper movie, he was just discharged from the hospital, right? And he's the one who shot him at the range. So the hospital is not the place for that. They need to be an effective therapeutic that has a high compliance. You come in, you do something, and then you can go on with that.
That's one of the reasons that we started this podcast is we know that the true healing, we can get started in the hospitals, we can get started with doctors, but it's going to take aftercare, which comes from our communities. Once the communities are involved and they know what you're going through, there's way more support available. At least that's how it was for me, because I started surrounding myself. I started adjusting my life based on the therapies that I went through to make sure that I built a community that would help keep me alive. And that aftercare is one of the things that is really hard for people to comply with. And so what we did is we tried to make it really, really simple. With 1 Mile, One Veteran, listen to the experts, listen to people in your community talk about these things, because honestly, we talk about a broken leg very nonchalantly. I broke my leg doing this thing. What I tell people with my depression, with my PTSD, I have PTSD. It's something that affects me. I have suicidal ideations. It's something that affects me. But guess what? When it does affect me, I have a treatment plan. I rest. I apply. I have a plan of recovery in place. And so, we want people going on that journey of adjusting their lives. So, if somebody was to seek you out for care, what would the procedure look like? And then what would you tell them to go do after getting the injections?
Great question. So, well, unfortunately, there's money involved. But let me tell you how our organization operates. Arguably, we're the best ones to do this because we are an international organization. So we have about 26 sites. Our flagship is in Chicago. We have 3 in Australia and 1 in Israel. So when people call us up, they talk to our psychiatric nurse practitioners. They do full assessment, physiologic, are they healthy enough to do it? If somebody has high blood pressure, blood thinners, stuff like that, we cannot do anything with that necessarily, but that needs to be controlled first. Psychiatrically, we also see, how are there, even at suicidal ideation, that needs to be addressed differently. And then we provide post-operative care, or if they have their own psychologist or psychiatrist, we'll do that as well. We'll integrate with them. But especially with military, I think there's a great advantage of being ex-military because there is a whole, especially I've seen how tightly knit special forces are. It's just a joy to see. I got to tell you, the thing that absolutely, I almost start crying with that, which I don't do that. I'm not particularly a crier. But we had, oh God, this is just crazy. So he was a major in SF. And he and his wife came in. I did the block on both of them. And they both developed headaches. It happens sometimes, whatever. So we had 1 Tylenol in the whole center. So we gave it to the guy. He goes, no, give it to the wife. The wife says, no, you take it. I was like, oh my God. They're arguing who is going to give the Tylenol to the other. That kind of mashing and commitment is just crazy. And the same thing is true for the guys. We've had people call me up. And he basically said he's the colonel in Green Berets. He said, one of my buddies got himself in trouble, blah, blah, blah. He shot up a truck. He didn't kill anybody, but he's in jail right now. You think you can talk to the judge to get him out of the jail, fix him, put him in the right facility, and he'll be okay? I said, okay. So I called the judge. He came. I treated him. And then we put him into Road Home, which is a Rush program specifically for military. He had a great result. He was able to reunite with his parents and his kids. But they called me and said, oh, you got to take care of my man now. I was like, okay. So, I mean, that's how it actually works. But in ideal, and to give you a direct answer, certain people after the procedure can come off the medication or significantly reduce them. There are certain drugs which I think should be addressed first. The one thing for the audience, I would say, one thing you never stop suddenly is Valium, Xanax. That can kill you. That can lead to seizures. Do not stop that drug. Other drugs you can stop, you'll be pretty miserable, but those just acute stopping like this could be very, very dangerous. And a lot of people don't know that.
Yeah, it's not greatly explained the potential consequences of coming off of some of these psychiatric medications when they're being issued to you. You're just told, don't just come off of them.
You're going to have a seizure and die. If you would have said that, it'd go, what, do we have something else?
Yeah, exactly. Maybe I would take something else. Now, I want to pivot a little bit because you've written a book called The Invisible Machine, and it highlights an unlikely team of people coming together: a doctor, an artist, a special forces leadership team, a sheriff, all working together. How did this collaboration come about, and what did each member bring?
Well, it was very, very interesting. So we have in Stellate Center, we have a lady, Dr. Springer, and then Shona Springer. So she knew Jamie Mustard. Jamie Mustard, he's a marketing guy, and he understands how to promote things, like labels on bottles, things like that. And then, so she recommended I treat him. So I treated him, and we got along well, and we started working together. And meanwhile, he was invited to go speak at Fort Bragg. It used to be called Fort Bragg, now it's called Fort Freedom. And that's how that connected. So he also connected to the sheriff, and he also connected to, I assume you're talking about Trevor Beeman, an amazing man, a special forces guy. So that eventually led to Trevor being on Portland TEDx last year. He's had a very hard life, and he has done unbelievably well. So Jamie was the one who's written a book before for Bandela Publishing, so that he called him up and I said, I'd like to do a book. So he and I wrote the book together. So that's how it came about.
Now, with the book, what were you guys hoping to accomplish? Like, what were you hoping the audience to take away from it?
Well, that PTSD is a real problem. It should be called PTSI. So people who support the book was Frank Egbert, surprising. Peter Levine, who's well known in trauma space, and some other people who are really like Stephen Porges, who's an amazing physiologist of trauma. So he came up with polyvagal theory. So the idea was to make it was designed, it's not supposed to be sciencey. I mean, it's sciencey, but it's definitely not science. But sciencey in the sense you can understand it. I'm trying to explain it in a relatively simplistic terms, but people are smart. They would like to understand where it comes from, how does that work. So there's some of that, but most of it are real-time stories. And I think Jamie had a good style of explaining kind of in a humanistic way what kind of people were there before, what are they like after, how did they all evolve, where did I come from, even this goofy guy, and I think some of my struggles in the space, I think are interesting, to put it mildly. I mean, what's the chance of somebody who is not really truly academic? I'm not a big chairman or anything, to give testimony in front of U.S. Congress in 2010. That's like, what? That's just crazy, right?
It's wild the rooms that you can find yourself in, especially when doing this book. And your book really goes into a lot more of what we were discussing here during this podcast. So I want to encourage our listeners, go check out The Invisible Machine. And as we bring our conversation to a close here, Dr. G, we talked about PTSI. We talked about the effects that it has on the family, the wives, the children, your own mother, my own personal life, and my near suicide. And these tragic events are going to continue until we can really truly find the solution collectively as a community, and start talking about these things and being open to these good modalities of care and follow on care, because we can't just take a pill and magically be healed. So until that happens, it can feel hopeless for a lot of our service members, veterans, first responders, and their families. Do you have a message of hope that you can bring to somebody that's currently going through the battle?
Absolutely. So again, we're going back to the poster. So brain, I don't understand it that much, but I understand plenty. Reality, how does the brain really work? And hope is all important. If there's no hope, there's no reason to live. So there is real hope. And I think DSR is one part of that hope. I hope it's a large part, but anyway, there are options available. So number one, we are here to help you. There are people who do care and they have effective modalities. If everything has failed, I don't think you've tried everything. And try something different, right? If this didn't work, try something different. Exposure therapy, in my opinion, is evil. That should not be done. I think it's a very dangerous technique. It's based on nothing, to me, and it's certainly not based in physiological studies or anything like that. Just don't do that. I would just say no to that, and I'll probably get in trouble with that. But whatever, not going the first time. But I think there are real modalities available, and know that you do have a real pathology. If you do have symptoms of PTSD, it's real. It's not because you're weak of soul or anything like that. It's because there is a real change in your brain, and it's possible to fix it. Whatever it takes, DSR, TMS, whatever. Certain medications are helpful. Maybe psilocybin, and even though it's not, I can't really officially endorse it. It's not legal in this country. But for example, I know there was 100 SEALs that was sent to Mexico to have it done, and they had pretty good results with that. So my point is, there is a number of things. Don't give up. Once you give up, then it's very hard. But also respect. So when it's the other things to the spouses of the people with PTSD, the same goes for you. Even though you have not been, I've had a number of people say, I should not be treated because I've never been to war. And nothing to do with that, right? If you have symptoms of PTSD, it doesn't matter where they came from, and realize they're real. Number one, they're real, they exist, and they can be treated.
Absolutely. There is hope for those of you that are truly seeking to get better, that are truly looking for the treatments. And so please, where can people learn more about you, your program, and how can they connect with you, Dr. G?
I'm a chief medical officer for Stella Center. So the website is stellacenter.com. If you're interested in sciencey stuff, you can go to dreugenelipov.com, and it has my publications. You can just read them. And I think for people who had TBIs, special forces, especially all of that, and mixtures PTSD, that is treatable. I think it is possible to make it a lot better. But like my friend Trev would say, you got me there, but I had to keep working to get me further. It's not going to be just, I have to do nothing. You definitely have to do something, and you need to be committed to getting better.
Absolutely. Well, I truly appreciate your time here today on the 1 Mile, 1 Veteran podcast. Thank you so much.
Thank you for having me. Thank you so much.
Absolutely. And for our listeners, remember, you can also catch the 1 Mile, 1 Veteran podcast on Reese Across America Radio. It's available for you on platforms like iHeartRadio, Odyssey, and the TuneIn app.